Good morning, guys. Uh, this is a part of our interview based workshop. This presentation is about profile. This presentation has two important components. One, talking about why profile is important, and then what are its component. I designed this program after observing several medical students and how they struggle in the interview. And now, looking into the theory, and I mean, in all the textbook, this is the format in which the cases are presented. Like there is a history, then there's an examination, then there's a diagnosis, and then there would be treatment. But however, in practice, this is not how it works. It is kind of a clubbed, and sometimes it is difficult to differentiate where the history ends and the treatment begins. Especially in psychiatry, the process of history taking itself could be considered as a treatment in terms of supportive psychotherapy, validation of human emotions, giving a sense of understanding. So now looking into the psychiatric history, there is an intense need to have particular structure into the psychiatric history taking. I would talk about it very soon, and this is a structure that I follow. And there are various other format in which the people take the history. This is the one that I evolved, and a lot of issues that could be covered in the profile could also be classed as a social background as a part of our developmental history. And there is a significant advantage in bringing those aspects earlier on in our assessment, because one, we want to have a supportive non-threatening way of interacting with the patient, which is one of the cornerstone of supportive psychotherapy. Now, looking into the other aspects of history taking, one of the main function of history taking is linking the person's present experiences and present life situation to their past, and also at a much more sophisticated level, linking their illness to their life experience, both in terms of the present and in terms of past. And this linking is very important. In terms one, it would give enhance human understanding of the person, treating them more than a patient, more like a person, and also giving a psychoeducation about how lifestyle choices lead to illness, and having a supportive and human understanding and validating their human experiences is one of the larger aspect of building a psychotherapeutic rapport. Now, psychiatric history taking itself would at least take around an hour or so, or sometimes it has to be carried on over by multiple sessions. So obviously talking about history taking would not be a small topic. I am sure that there are several classes that you need to attend. All these classes would add on to your ability to take history and would enhance your abilities. So I won't go into the details of each of them. We would come in separate categories, like when I talk about each of them. Now let's address why profile is so important. Most common reason why profile is important is it reduces the anxiety in the interviewer. Especially as a medical student, one, you would be anxious about being observed in the examination situation. You could be anxious about seeing a psychiatric patient. There are several myths and misunderstanding which could feed into anxiety. In one of the thing is psychiatric interview, unlike medical interview is full of chaos, and people would love to have some kind of order and some level of predictability, and so the profile provide this aspect. And another is human life is highly variable. People come in various forms. Their life story is very difficult, uh, and there is and the intense need that there should be some level of a structure so that the people can understand how everything fits in one place. The profile provides kind of a backbone, a scaffold on which the uh, curves of human life could be drawn. And from the patient point of view, one, there's a need to make the interview quite normal, and our attempt should be to build the rapport as soon as possible. And if we go into the symptoms quite soon, there is a chance that we would lose that rapport quite soon because we start seeing them as a patient. And if we start talking in a normal things like the place they live, the family, job, and those kind of things, which are quite normal things to talk about, it would help to normalize the interview, reduce the patient's anxiety, and build the rapport. And you would also come across as a quite supportive person. And other is there is a there is a valid good research to show that people arrive at diagnosis within 5 minutes even without really asking about the symptoms. So asking about symptoms is not that important. What is more important is talk of how you begin the interview and what happens in the first few minutes and how you can go about it. And knowing the details of the profile and the reasons behind it would help you to master that aspect first 5 minutes of the interview. So you would know what are the kind of things that you would expect and what it means if you find one thing or the other. And that's what this profile is all about. And profile gives you the context of the person's life, and in that sense based on that the every other aspects of psychiatric history depends. And if you miss the context, you are going to miss everything. You are going to land in a disaster. This is not a forest, this is a lake. And another is one of the major criteria for any mental illness is disturbed functioning. Given the variety of the patients, their psychosocial circumstances, you need to have some level of easy to use structure where you can easily assess functionality of the patient. Unless the functioning is disturbed, you can't make a diagnosis of psychiatric illness. So how are you going to assess the functioning? Even though I'm not going to go into the detail, the main way that people you assess a functioning of a person is looking into their psychosocial background, like their situation, their accommodation situation, their interpersonal context, their ability to function at work, to take care of themselves, help others, and so many other dimensions like intellectual functioning, spirituality, so forth. All these things are, you can see that they're just part of the profile. Another major thing, a system, Australian health system would emphasize is the risk. Risk is everything. Okay, that's how most of the system is built in Australian context. So let's look into, there are various risks, I mean in terms of suicide risk, self-harm, aggression going on to homicide, and so forth. So how would you assess? And the one person can have variety of risk factors. So way I would look at it is there's a baseline level of functioning or baseline level of risk for a person, and after a kind of a stressors, they are going to have, say, kind of a mental illness, and their risk increases remarkably. And in that context, we say that there are static risk factors and there are dynamic risk factors. And the static risk factors are one which are present all through their life. They are not going to change significantly. The dynamic risk factors are one which are could be treated. We need to understand those and design the treatment appropriately. So you can cover majority of the static risk factors under the heading of profile, and you can focus on the dynamic risk factors when you analyze the presenting problems. So it's important to take the profile. To give an example, elderly male living by himself, partner has passed away, has a higher risk of suicide. Same way, young male has a heavy history of substance use is also known to forensic services. You need to be cautious about aggressive outburst. Young female recently broken up from the relationship, had a difficult childhood, very high risk of self-harm. So this is nothing to do with this psychiatric symptoms. It is all about psychosocial background. So profile is important. Next, profile itself also give you clues about the diagnosis. To give an example, a homeless man with minimal contact with family, think of schizophrenic illness. A person in medical ward, elderly person, consider dementia. Okay. And other aspect of it is most of the psychiatric treatment could be classified as biological, psychological, and social. But however, the treatment depends upon the etiological factor affecting the same domains. And one of the most common thing that we come across is the stress causing mental illness. And most of the treatment is around how you help the person to cope with stress. And there are variety of stressors. And if you look into the kind of stressors the people face, you can see that all of them could be classed as part of the person's profile. So I would say taking profile, it already has given you enough information on the stressors. And other is not all stressors causes mental illness. There should be some specific reasons, and if you want to understand that, uh, you need to know good profile, because the symbolic link between the current stressors and the past trauma lead to mental illness. But however, the mental illness per se could also have several gains, so that can keep the illness going on in terms of social benefits people get if they are recognized as mentally unwell. So those factors also could be covered under profile. And mental illness can itself uh, make person dysfunctional and cause stresses. So at so many levels it became chicken and egg kind of a question. So in that sense, again, you need to know how things started. So you need to be quite systematic in evaluating all these things. Another thing that you need to worry about in psychiatry especially is it is not what you really see. Things are entirely different compared to what people present you. If the person present to you with suicidal idea and depression, it is not necessarily that it is a depression that's causing this person suicidal at this point of time. It could be relationship breakdown or alcohol use. Now, the person could be using alcohol on a regular basis, and the family is quite fed up with him, and they threaten to kick him out of the hospital, their home and then he threatened them back with suicidal ideas. It could happen. And there are, because there is significant level of uh, social benefit if somebody is identified as a mentally unwell, so there could be, the people could mm, uh, elaborate or embellish their symptoms. And it could be also lack of insight, where the person may minimize the symptoms of psychiatric illness. So you're not going to, you don't know when you see the patient in the first time and which category this person would belong, whether this person is maximizing or minimizing his symptoms or life issues. We don't know. So understanding the profile would help you to tease out this kind of subtle things. Now, looking into the profile per se, these are the 8, there are 10 or 11, 12 major issues that you need to cover under the heading of a profile. You should try to cover as much as possible, um, and but you need to be quite flexible. But you should not jump from profile to presenting problem uh, earlier. You should insist on the order. There is a use to it, and we'll go each one of them. Okay. Now, gender, obviously, it is quite easy to recognize, and that itself would give you a clue about uh, how you are going to interview and what issues that you are going to inquire and how you are going to inquire and all those things. But when it is confusing, then the history would be much more interesting. If there is issues around sexual identity, sexual orientation, and be upfront and be honest, most of the patients would appreciate that, because that could be one of the core component which is troubling this person for a long time. So if there is an issue, just go directly and ask about it in a sensitive manner and respectfully, and explore the difficulties they basically the name. People just stop, sometimes we just ask their first name, they may not ask the full name. But I would say that people should show more interest in the name of the person than just taking the name. Okay. And there are multiple uses to it. What I would suggest would be asking their full name and how they would like to be uh, called, and what is it the right way of pronouncing, is it the right way of spelling it, and all those things is important. And also, in sometimes when it is slightly odd or striking, ask them where did this name come from. It could be Eastern European name or Asian name, and it may have some specific meaning, or the person or it is spelled in a different way, it may give a different cultural context. This kind of opens window into the developmental and family dynamics within few seconds of the interview. And don't be afraid to do so. And people do really appreciate your keen interest in the human being, not just as a patient. And other is, if there is a change in the name, now it could be due to marriage, and that itself could tell a lot about it. I mean, just remember that Angela Merkel is currently married to a second one husband, but she still keeps her first husband's family name. So it would tell something about that person. And also, the change of name could also indicate, it could be antisocial personality, or it could also indicate mania, or you know, uh, psychosis, or it could also indicate psychological struggle. Like, the one of the famous person, Erik Erikson, changed his family name uh, because he was not happy with his stepdad. That could be the reason. And Other is age of the person. Now, most of the people would ask this. Uh, in an elderly population, I would suggest that you can ask date of birth. There's not much gain in asking much younger person, but in examination you can get on by asking date of birth as a kind of a documentation purpose, as a identity purpose. I used this particularly to draw a developmental line, putting the age and year in one particular order. This is very, very important, and it's important to do it quite early on, because as you go into the interview, there's a lot of issues that could come up, and it would be very difficult to keep track of how things have happened. And you being quite structured and trying to make sense and how each of them fit in each other would give a kind of a feedback to the patient that you are really interested but also would like to really understand the problem, not just here to listen to the emotions. No, that also kind of a building block towards problem solving. And drawing this kind of line also could act as a kind of a reminder about the developmental issues that you need to look for in this particular age group. The common mistake that I see in this at this stage, usually the people jump from the age into the presenting problem, how you came to be here, what can we do for you, such kind of things. People should restrain from themselves from asking that. The main purpose of the profile is to help the clinician to orient to the person, uh, and this orientation would involve the orienting in terms of geographical location, the relationship context in which this person is living, and his level of functioning. Those are the more important aspect. So I would strongly recommend that people should slow down at this stage and be methodical. So the next aspect, as I would suggest, would be the residence. There are, especially in a psychiatric population, you are bound to see significant instability. You are going to see wide variety of situations. Some people could be homeless, some people could be living in the same family unit with their parents for a couple of generations. So each of those things would tell different things about the person. So show keen interest in asking about where exactly they live, where exactly do they live, and and how long they've been living in that particular place. And if you sense that there is a level of instability, like being homeless or couch surfing or changing house every couple of months, do ask them then and there about where else they lived and how often they have changed, where is the longest where did they live for longest period of their life, and do explore itinerant aspect of their lifestyle. That's going to have a huge impact, because that's going to play a huge role in their further management post discharge, where you're going to place them. And it's also give a clue about the factors that could be contributing to their mental illness, or how mental illness is contributing to their itinerant lifestyle. Like a manic person or schizophrenic person who is uh, avoid escaping from the persecutors, may change one home after the other. That kind of things can happen. The other is asking the details of the current house is also important. In a homeless person, you may have to ask about where exactly do they live in the night. Of course, in Queensland, it may not be hugely different, but especially if they are living in a metro area, there are safety concerns. And in a rural area, you may have to ask about the social network and what are the other things around that. And backpackers, shared accommodation, the environment there, or the so forth. See, I had old age psychiatry in this team, and I emphasized asking the details of residential history in elderly population. Especially, this gives a huge clue both in terms of risk of fall and their functional capacity, the level of supports that they need. You may have to go into the details of terms of how big is the house, can they maintain that house, is it a one-story building or two-story building, does it have stair, and what kind of supports they need, practical, like can they go to the uh, bath and so forth. And they could be in a nursing home. That also raises several questions about what kind of nursing home, is it a high level care, low level care, or a retirement village kind of a setup, what kind of supports are provided to them in that particular facility, how they landed up there. Those kind of a practical inquiry is extremely important. I'm just going back to this residential history. Uh, Here, there is also, it could be intermixed with the immigration and the cultural issues, or it could be Australian, but it could be running around all over the Australia. So tracking their uh, residential history along their timeline of their life would also give you clue about the kind of stressors that could have been there in their life without directly asking for the stressors. And so I would recommend that people should familiarize themselves for uh, common towns around the places in Bundaberg. And but I have to say that majority of my patients would not have this kind of a glamorous history. They would be living in a remote farm, isolated far away from the local pharmacy and healthcare services. If something does happen, it is quite difficult for them to seek help. It would also raise the question of about transport, and a person living in farmhouse, owning a gun, drinking alcohol, all those things could play a huge role in the risk assessment. Usually, after the residential history, I move on to the relationship issue. It kind of gives a smooth transition for me. Usually, I ask them, do they live by themselves, or do they live with somebody? And that kind of gives a window, and I would further elaborate. I generally avoid, do you live by alone? Such, that particular aspect I liked it. The other aspect that I have noticed is usually generally people are hesitant in asking the relationship details, especially quite early on in the interview. I do acknowledge that in a normal social interaction, we generally don't ask people's relationship status. We would consider that as too intrusive and socially inappropriate to do so. But the in a psychiatric interview, it is very important that you ask about the relationship and as much detail as possible. You need to be sensitive, but you can't ignore that. All human emotions, inner experiences, and behaviors are more intense in an interpersonal context. And so it is important that we need to understand the relationship. And considering that this is quite similar to asking a physician asking people to disrobe if he has to do a good respiratory and cardiac examination. This has to be done in a most professional and non-judgmental supportive way. But if you don't do it, then also you have not done any examination or any service to the patient. You can't hear heart murmurs uh, through jump on. You had to ask them to remove their shirts and jumpers before you really understand what's going on. Otherwise, you can't help them. So I generally try to draw a brief family tree as they talk about it. It could include uh, the person, the age, and whom do they live with in terms of their partner, a bit of details about them, and the people who live with them in terms of sibling, uh, so forth. And also ask about their family in terms of what social support do they have. Do they have family living close by? Where do they live? And how does it all fit into their social network? This is a kind of general inquiry that I start off with, and I also closely monitor how the person react as they talk about each individual person in their family network. And some people would outrightly oppose, why do you want to know about my family? That itself is a clue about huge pathology, and you have to figure out why it could be. Now, in some situation you may have to educate the patient about why it is important. Sometimes you may have to let them go and come back in some situation, or sometimes you may have to say to them, that's okay if you don't want to talk about them, but can you help me understand why it is difficult for you to talk about it? I think it is painful, but would it be okay if you can tell me uh, the reasons behind uh, why you don't want to talk about family without really giving me anything about your family? That kind of opens up things. You can't avoid this. And also this is my theories are based on my orientation in terms of psychodynamics and also interpersonal therapy. And I believe that all the relationships are in a way are quite interrelated, and they kind of form a pattern. And even though the people can complain about their current partner, all those things actually fit into a larger pattern. And if people start seeing the larger pattern, then it is much easier to foster the responsibility to change it. And don't be surprised, people would give you a family tree initially, and as you uh, do the interview and collect the collateral information, the dynamics within the relationship would explain so many issues. And initial family tree may not match the uh, corroborated or refined family tree, because it does indicate significant psychopathology. And especially in elderly population, don't ever stop asking about their pets. They are quite important. They kind of for so many people they give them kind of a emotional support and meaning for their life when there is no social support. And also it is quite important in people with schizotypal personality, uh, about their investment in their pets is quite enormous. Moving on, the job is one of the uh, not Steve Jobs, I mean, job creates identity for people. And if there is no job, that's a huge injury, narcissistic injury to any human being. And also the job gives a structure to person's life. Full-time job, no job, that would have an impact on the person's structure of the day, how they spend their life. Like even for us, getting ready early in the morning, coming to work, and then after going from here, going to childcare, picking up the kids, all those things, it's, at so many levels are quite structured, and that itself could keep person um, straight and narrow and functioning well. At the same time, they could also act as stressors. So ask about the details of each person's job, their level of job satisfaction, and importantly, insecurities around their job. The important. and inquire about if there is no job, which is quite common in a psychiatric population, people on disability support pension not being working. Ask about their typical day, how they spend their time from that would give you a huge clue about their function, not only about functionality, sometimes also into their psychotic symptoms or depressive symptoms. If somebody says they've been going to jogging and visiting pub, meeting people, and then they come and say that I are highly depressed, you have to wonder about it. And somebody who is highly paranoid has been staying home, monitoring the neighbors, changing the locks, you may have to wonder, even though he denies all the delusions, there's a clue that he is delusional. Next issue would be the finances. Uh, People are generally quite cautious in exploring the financial aspect of another human being much more than a relationship. But especially if somebody is not working, it's fair enough to ask where did the income come from, what kind of Centrelink benefit do they have, and in some cases it is quite important, say in terms of dementia, cognitive impairment and their financial capacity, or in terms of mania and excessive spending, or substance use and pathological gambling and their impact on financial, or the finances could be major stressors leading to the depression. So don't hesitate, this is also one of the important aspect you need to ask. Next one would be linking with the other services. Don't ever assume that the patient, this is the first time that they are presenting to the uh, interview, especially for those who are given to the medical student. They are quite well known to the mental health services or variety of health services. So ask them that what other services they are known to, uh, including drug and alcohol, or any other, like cops. Are their finances being controlled by public trustee? Are they been supported by NGOs or disability support workers? All those things would also give clues about the longitudinal diagnosis, even without really asking in detail. And from there, you can ask about their symptoms. Other in Australian context, I've observed that people don't really ask much about the person's education, especially in the initial part. Uh, Back in India, where I've tried, asking about education was a very important aspect. It did give a huge clue about their intellectual capacity, and also if there is a mismatch between the intellect and educational achievement, or if there is a mismatch between educational achievement and social attainment, uh, there is a huge clue about the kind of difficulties that you could anticipate. Another aspect that I would love to explore are the religious aspect. Even though Australia is a secular country, the people are not secular, and we are multicultural society. Religion do play a huge role in people's life, all across the globe, across the time, and it gives a kind of sense of identity, sense of belongingness, and it also gives you values and guiding principles or a purpose to the life. So it is important, and this is particularly important, especially if you are exploring a suicidal risk, exploring the afterlife and cultural beliefs around those kind of suicide or any kind of risk activities are important, and this would enhance your rapport and individualizing the interview. Okay, we can ask all this kind of things, so many times people wonder, if we ask so much detail and at the end of it, where should we go? The common answer would be, from profile you move on to the how the person came to be in the hospital, and then go and ask about their symptoms or illness, and maybe ask a bit more details about developmental history if needed. Okay, this also depends upon the stage of their illness. If somebody present in an acute crisis, possibly it's not a worth good idea to explore about the profile at this when they are going through acute crisis. But when they are only symptomatic, there is no acute risk or immediate urgent management issues. It's not a bad idea to ask detailed profile. And and also there is another challenge that can happen, especially when there is no symptoms. It could happen in a community setup where the patient has been seeing mental health services for a long time. They currently don't have any particular symptoms, and they particularly don't have any acute concerns, and they've just come for the follow-up. They don't have any symptoms, they don't have any problems. So what would you explore? Now, in those kind of situation, it's not a bad idea to go directly from profile to get a family tree and asking about their life developmental history, and from then track the back into the symptoms and uh, how they came to be in the hospital, and what are the current concerns. It's not a bad idea. I do this quite often, so don't be hesitant to do this. Other is, this is based on the premises that the profile is a kind of indication of the developmental history. So I repeatedly emphasize that people uh, do not to shy away from moving on to developmental history from profile instead of pathway, especially if you can guess at the end of 5 minutes of interview, sense that there is no acute symptoms right now. Possibly you can move on to the developmental history instead of trying to ask about the symptoms which are the past history. So obviously the profile itself would bring significant challenges. No, uh, this is a very sensitive area, and we have to begin with that. And as I talked about it, there are so many of them are personal, sensitive, shameful information can come up, and that has to happen with a perfect stranger within few minutes. So you need to have a very good attitude towards another human being and attitude towards life in general, and that could be one of the major factor why people can't get good history. Instead of blaming the patient, possibly it should be better to look at our own judgment and way of asking question. And some people also struggle, if you have to take so much of details, they struggle with identity crisis about their own profession. Are we doctors? Uh, that superiority complex, narcissistic injury could come. And also if we start asking about so much details in their demographic profile, how are we going to control the interview, manage the interview? Mm, that's another issue you may have to struggle. And also the time management. You are only given 30 minutes in exam setup, and how are you going to manage that? Those are the things that you need to learn in the process of interview. Okay, just briefly, how are you going to overcome it? And obviously, knowledge, your attitudes and beliefs could be changed by knowledge in terms of reading about mental illness, reading about human psychology, and also improving your interpersonal skills and interview skills, and also reflecting on your own life, your family life could help to overcome this barrier. And also sometimes when you don't get an answer from the patient, educating is one approach, and also taking a no as an answer could be another, or coming back at sometime later would be answer, or just empathizing with the emotional impact of it and maintaining the silence without really asking any new questions would also help the person to process the pain, and then slowly opening up and talking about that could happen. And at the end of the day, you don't know, you are going to make mistake. Don't be afraid of making mistake, so go ahead and do. You would fail, but that's how you would learn. So now moving on to the practice, um, I would advise that all of you practice in your own time in addition to what we do now. Uh, like possibly writing your own demographic profile in detail would help, and also just sitting with your family members and practicing those questions would also help because it's less threatening. And if you have a close friend or a colleague, you can do that. And also uh, catch an opportunity and spend a lot of time in our inpatient ward in a non clinical uh, situations, and interact in a casual manner and seek the permission and get those details. It's good exercise. Okay, now coming to the practice per se, we have asked few of our staff to act as a patient so that you could interview them, and we have done this considering that you would be quite anxious to see a psychiatric patient on the day one, so we wanted to reduce your anxiety as much as possible. I wish you all the best. Okay, thank you.